So if you're going to give a female that desires fertility soon in the future, then finasteride on paper would look like a better option. But in practice, females tend to tolerate dutasteride much better than finasteride.
This is an interesting heading here. They have treatments with limited but promising scientific evidence for efficacy and safety in PMDD. And we'll circle back to some of these studies and make some comments after we go through them in entirety, talk about some of the specifics that we thought were interesting or concerning. But we have 5-alpha reductase inhibitors. So finasteride specifically has not been studied in this regard. Dutasteride has been studied in this regard. And they used 2.5 milligrams per day. And when they used that dose, they were able to inhibit the conversion of progesterone to dihydroprogesterone. And then downstream, you're missing out on allopregnanolone. So we go back to this concept of allopregnanolone or GABA A stability. And if you have, a stable level of allopregnanolone, good. If you have a high level and it stays there, good. If you have a low level or a essentially undetectable level, then you also don't have fluctuation and you will improve symptoms.
Yeah, this is kind of interesting because 2.5 mg per day is a very high dose. And I believe another study showed that 0.5 mg per day did not have efficacy. And we do know that looking at, not from large clinical study, but inferring from preclinical studies, dutasteride likely leads to less suppression of progesterone converting to DHP and allopregnanolone, its neurosteroid derivatives, than finasteride. So you'd think that finasteride would have more efficacy at a lower dose, but and also a much shorter half-life. So if you're going to give a female that desires fertility soon in the future, then finasteride on paper would look like a better option. But in practice, females tend to tolerate dutasteride much better than finasteride. We've done several episodes on finasteride syndromes or different effects of dutasteride, finasteride, the 3 different isoenzymes of 5-alpha reductase. 5-alpha reductase is actually 3 enzymes, 1, 2, and 3. And we don't need to get into too much detail or specificity here. But the main limitation of this would be the dose of dutasteride in a female that desires fertility that's relatively soon. A lot of times dutasteride is given at very low doses, and perhaps if they design the study differently, they could look at something like a single dose or 2 days, but likely just a single dose of 2.5 milligrams of dutasteride around day 21 of the cycle. And that may have just as much efficacy because it gets to that threshold where it's high enough and it is metabolized slow enough at that high of a dose, again, dose-dependent half-life, to where it might still have efficacy.
Yeah, it'd be an interesting one. What I'm thinking of when I see this is, presumably, let's say you have a woman who's taking this uninterrupted. We know that men who are taking, and older men, granted, taking 0.5 milligram of dutasteride per day, they miss a month and basically their DHT levels are unchanged. They start to trickle up a little bit, but it can take several months for that dutasteride or the effect of the dutasteride to be out of your system at 20% of this dose. So, these would be younger women. So in theory, they would metabolize a little bit quicker, but it's still a hefty dose. And you would definitely want to look at, reproductive counseling, like all of these treatments, right? You wouldn't take out somebody's, uterus without doing some reproductive counseling. I hope. You wouldn't put someone on a GnRH analog without some reproductive counseling.
Unless they have endometriosis.
Yes, then that does happen,
then it's
unfortunately, too often.
Yep. We've seen it many times personally as well. Not to get off onto too much of a rabbit trail. We'll dive deep into 5-alpha reductase inhibitors again in the future. There's a lot of misinformation around there. There's no such thing as a dutasteride syndrome if you have normal testosterone. And women and men both, as we've mentioned, have different androgen receptor sensitivities. that we know of, there is no DHT receptor. There is no allotestosterone receptor, also known as androstenediol. We'll talk about that more later too. Lots of teasers today, but that should sum up dutasteride as a treatment. And next we can talk about what we mentioned earlier. Why not just use bioidentical HRT instead of oral contraceptives?
Well, this is actually synthetic HRT again. Disappointing. We'll get to the bioidenticals eventually. We had to actually dig in and find those studies on our own because they didn't make it into the guidelines. But
yeah, you shouldn't put a guideline on a bioidentical hormone. It might actually work.
Makes it too simple. So they used a technique, ovulation suppression, using a synthetic progestogen, cyclically, and then with transdermal estradiol because you do, at least you're giving some hormone add back there. Perhaps not enough. Even with the GnRH agonist and hormone add back, they don't add back testosterone, which is the most abundant hormone, like we pointed out and like we outlined on our chart. But anyway, that's a bit of an aside.
By the way, when you don't add back testosterone and you add estrogen and progestogen, whether it's bioidentical or synthetic, you suppress endogenous testosterone. So that might be therapeutic in someone with really significant androgen dominance, or it might be causing side effects in someone with baseline low level of androgen.
Absolutely. So they did this small study. There's downsides of increased risk of blood clots with these synthetic progestogens. I don't know that this would be superior at all to basically, like they pointed out, a contraceptive that contains drospirenone. But the study was done, and props to them for putting it in their chart with I guess about a dozen different options and studies that have been done.
Yep.
And then we have quetiapine, which it said would be used as an adjunct to SSRI. And this is where, again, this is a very small dose of it, but giving someone 25 milligrams of quetiapine is probably going to make them, too tired to feel stressed out?
Yeah, I guess so. Presumably this is given in the evening, like amitriptyline is off-label often to help them sleep better. I suppose if most of the symptoms are during sleep, then it could help, but it doesn't seem like it's certainly not a great go-to option or a very good root cause option, assuming that you've done your diagnosis of exclusion correctly.
Yeah, I suppose if you give someone an antipsychotic and it's a dysthymia that you've misdiagnosed, then congratulations, you have successfully treated the patient. It's like the math problem meme where the teacher says you did all the work wrong, but you got the right answer.
Yeah. And then I suppose you could make a case that if someone's been taking even this low dose of quetiapine, do we know if they took it for just 1 week or if they took it all month?
Yeah, we
during
don't know.
The luteal phase, perhaps just during the luteal phase. So if it's just the last 7 days or last 14 days of the menstrual cycle, then that's more reasonable because they're less likely to gain a bunch of weight and then aromatize even more and have even more estrogen dominance and then have more menstrual irregularities. But I suppose you could cover that up if you gave them Seroquel and an oral contraceptive pill. That would be your ultimate. Don't treat the pathology, cover up the symptoms, and deal with it later stack. An oral contraceptive and Seroquel for the last 7 to 10 days.
It's a pretty effective cover-up.